Hi, I'm Brian Mandel, the editor-in-chief of the Cleveland Clinic Journal of Medicine, CCJM. Welcome to Beyond the Pages, CCJM podcast, where we will take you in depth into the content of selected articles from the Cleveland Clinic Journal of Medicine and explore a few interesting tangents along the way. Through moderated interviews with our authors and other experts in the field, we hope the clinicians will gain a more nuanced perspective of clinical concepts that are changing the practice of medicine and be able to apply this perspective to the care of our patients.
Thank you for joining us on another episode of Beyond the Pages, CCJM podcast. I am Dr. Craig Nielsen, staff physician in the Cleveland Clinic's Department of Internal Medicine. I serve as one of the vice chairs for the Department of Internal Medicine and Geriatrics, and I am Assistant Dean for Clinical Education for the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University here in Cleveland, Ohio. Today, we're going to talk about the article published in the Cleveland Clinic Journal of Medicine, Glucocorticoid-Induced Adrenal Insufficiency and Glucocorticoid Withdrawal Syndrome, two sides of the same coin. Today, I am lucky to be joined by all three authors. We have the first author, Dr. Nora Nechawi, University of Michigan, Ann Arbor. Welcome.
Hi, thank you for having me.
We also have Dr. Dingfang Li and Dr. Cecilia Lansang, both of the Cleveland Clinic's Department of Endocrinology, Diabetes, and Metabolism. Welcome, Dr. Lansang.
Thank you, Dr. Nielsen. I am happy to be here.
And welcome, Dr. Li.
Thank you, Dr. Nelson. I'm happy to be here as well.
And thank you all for joining us today. Now, let's go beyond the pages. I thought it would be helpful to start with some basic definitions of the conditions we'll be reviewing today. Adrenal insufficiency, glucocorticoid-induced adrenal insufficiency, GIAI, and then lastly, glucocorticoid withdrawal syndrome.
Thank you, Craig. I think it's very important that we put a delineation to these terms because when we start out right, then we understand the entire pathology. So when we talk about adrenal insufficiency, in its simplest sense is that we don't produce adrenal hormones. But in this context, we usually do not talk about the adrenal medulla, which produces catecholamines. We are really talking about the adrenal cortex. The adrenal cortex, though, is divided into three zones, producing your glucocorticoids, which we know mostly to be cortisol, the mineralocorticoids, of which aldosterone is the representative, and then our sex hormones. However, since our sex hormones primarily come from the gonads, we do not speak of them usually in this context of adrenal insufficiency. Now, the glucocorticoids are under the control of our pituitary gland. And so when there is a secondary cause of adrenal insufficiency, we usually mean that the pathology comes from the pituitary. There's even a term, tertiary adrenal insufficiency, which means that the disease comes from the hypothalamus, but most of the time these two, secondary and tertiary, are lumped together. When we talk about primary adrenal insufficiency, there is a lack of both your mineralocorticoid and your glucocorticoid hormones. But remember that the mineralocorticoids are not controlled by your pituitary gland and the hypothalamus. They are controlled by the renin-angiotensin system. So they are not going to be discussed here. If we are talking about glucocorticoid-induced adrenal insufficiency, that means a person is exposed to such a dose and length of time of glucocorticoids such as prednisone, dexamethasone, hydrocortisone, that the hypothalamus and the pituitary gland are not sending signals to the adrenal gland. The adrenal cortex is then atrophied and cannot produce cortisol on its own. That is what we call adrenal insufficiency. On the other hand, glucocorticoid withdrawal syndrome is when a patient may already be getting exogenous steroids, but because the doses are decreasing, the body feels that there's some lack of it, and the symptoms that it produces may be similar to glucocorticoid-induced adrenal insufficiency, but that patient still has enough exogenous glucocorticoids on board.
Thank you, Dr. Lansing. As an endocrinologist, why do you think this is an important topic for our internal medicine audience?
I think that the clinician needs to know if it's GIAI or GWS, because it might spell the difference between giving the patient yet another high dose of steroid as if to treat adrenal crisis, which we see in glucocorticoid-induced adrenal insufficiency, that the patient just doesn't have enough of the steroids on board to mount a stressful situation, such as, let's say, an infection or a major surgery, as opposed to glucocorticoid withdrawal syndrome, where maybe the dose of the steroids is already beyond and above the physiologic dose, but yet it's just having symptoms, and we don't have to give the stress dose. We just maybe have to increase the prednisone dose a little bit so that the symptoms disappear.
Thank you. I really appreciated that answer. Dr. Nachawi, I found it extremely helpful that your article outlined medications other than steroids that can affect the hypothalamic pituitary adrenal axis. Can you review some of these medications for our audience?
Yeah, of course. Happy to do that. So I think the biggest one that really causes suppression of the hypothalamus pituitary adrenal axis, the HPA axis, is actually the opioid. And we have so many patients on opioid. So the question becomes, when would we suspect adrenal insufficiency in these patients? And the evidence we have from small studies highlight how patients who are actually treated with chronic opioids for at least 3 to 6 months and a dose of at least 20 morphine milliequivalent on daily basis, these are the patients who are likely to suffer from adrenal insufficiency. And these patients actually will need to be treated with glucocorticoid replacement until the opioids are weaned off and the glucocorticoids later weaned off and their HPA axis recover. I would also like to highlight one of the new emerging medications that are used in the oncology world. And these are actually the immunocheckpoint inhibitors that are now being used more commonly to treat a lot of malignancies that we're seeing. These medications, such as the CTLA-4 blocking antibody, the ipilimumab, the anti-PD1 monoclonal antibodies, the nivolumab, and the pembrolizumab, all of these immune checkpoint inhibitors could actually affect the HPA axis in 2 different ways. Most commonly, they have been linked to cause what we call autoimmune hypophysitis, leading to inflammation and hypophysitis, and that leads to a picture of secondary or central adrenal insufficiency. And in very rare cases, these medications have been linked to autoimmune adrenalitis, where they affect the adrenal cortex, leading to glucocorticoid and mineralocorticoid deficiency. Another class of medication that could affect the HPA axis are the ones that suppress the glucocorticoid gene transcription, like the empyramine and the chloropromazine, and other classes of medications that inhibit steroidogenesis, the antifungals like the ketoconazole and the fluconazole. And I think one of the most common medications that are used in the intensive care unit and it causes adrenal insufficiency by inhibiting steroidogenesis is the etomidate. We see that quite often, and we get consulted a lot in the inpatient setting about patients having hypotension, and they have used the etomidate have been used for them. And very rarely there are cases where some anticoagulation medication like the warfarin and the heparin could cause bilateral adrenal hemorrhage. like the heparin and the warfarin, and that could lead to adrenal insufficiency as well. One of the most important class of medication that I would also like to highlight are the medicines that interact with the cytochrome P450 3A4 and induces this enzyme, which lead to increased clearance of the cortisol, and that will make these patients suffer from cortisol insufficiency. So these medications include the phenytoin, the barbiturate, the rifampin, and the mitotin. So these are actually the most common medications that are used. So I hope that I answered your question.
Yes, very well. Thank you. Now I thought we would take a little detour and go into a little more detail specifically about glucocorticoid-induced adrenal insufficiency. Namely, what are the risk factors for GIAI in regard to dosing of glucocorticoids, duration, formulation, and timing of administration?
Yeah, so there are multiple factors that play a role in patients developing GIAI while tapering down the glucocorticoids. And before I go over these factors, I would like to mention that we really don't have a high quality evidence on these factors. Most of the evidence we have comes actually from observational studies, handful of small prospective studies, and few systematic reviews and meta-analysis. So the first factor that I would like to start with is actually the glucocorticoid dose and duration of use. And the evidence behind the dose of glucocorticoid is actually conflicting. But the data we have from a large systematic review by Borenson in 2015 shows that patients who are actually treated with high doses of glucocorticoid, and that's defined as a dose of at least 20 milligrams of prednisone on daily basis or any equivalent glucocorticoid. So patients who are treated with these high doses have an absolute risk that reaches up to 21% of developing GIAI. And when they compare that risk to patients who are taking medium doses, anywhere between 5 to 20 milligrams of total daily dose of prednisone or any equivalent glucocorticoid, the risk was actually 8.5% of developing GIAI. And patients on lower doses, less than 5 milligrams of total daily dose of prednisone, had a risk of 2.4%. So this is such a big difference. And it seems like the risk of GIAI is dose dependent based on these numbers. In terms of duration, it seems like the longer the duration of glucocorticoid use, then the higher risk of developing GIAI. The same meta-analysis noted that long-term of glucocorticoid use longer than 1 year was associated with the risk of 27% of developing GIAI, whereas use of glucocorticoid between only a month to a year was associated with 11.9% risk of developing GIAI, and short-term use of less than 1 month was associated with a risk of 1.4% of developing GIAI. So again, it seems like the number are pointing into longer duration being linked to higher risk of developing GIAI. Another risk factor that I would like to highlight today is actually the glucocorticoid potency and duration of action. So as we know, different glucocorticoids do come with different potencies. For example, dexamethasone potency is 25 times higher than hydrocortisone, and prednisone potency is actually 4 times higher than hydrocortisone potency. Similarly, duration of action of dexamethasone is actually much longer and could exceed 36 hours whereas prednisone duration of action could reach anywhere between 18 hours to 36 hours, and hydrocortisone duration of action lasts only 12 hours. So when these three different glucocorticoids are used at equivalent doses, it was noted in small studies that dexamethasone had more suppressive effect on the HPA axis compared to hydrocortisone. But when they compared the dexamethasone versus the prednisone, there was really no significant difference between the dexamethasone and the prednisone. And this is important for treatment of GIAI, and we'll probably go over this shortly when we talk about that. Another factor that plays a role in developing GIAI is actually timing and frequency of glucocorticoid administration. The evidence we have from small study showed that patients who receive prednisone in one daily dose have less suppression of their HPA axis compared to patients who receive the same daily dose but in divided doses. Similarly, patients who receive prednisone every other day have less HPA axis suppression compared to patients who receive prednisone on daily doses. In terms of pulse therapy, patients who receive pulse therapy in high doses over 4 to 6 weeks for one time have less suppression of their HPA axis compared to patients who receive frequent pulse therapy repeatedly every 2 weeks. So all of that indicates that the higher the frequency and the timing plays a big role in developing GIAI. Another important factor is actually interaction with other medications that inhibits the enzyme, the cytochrome P450 3A4. And these medications they are actually used commonly, and they include antibiotics like erythromycin, quinolones, protease inhibitors that are used for HIV treatment, and other medications. So when these inhibitors are used concomitantly with the glucocorticoids, they lead to slow clearance of the glucocorticoid, which in turn leads to more exposure and then more HPA axis suppression. So all of this is important to keep in mind when evaluating patients. I have to also note that some authors in the literature have noted that sometimes when you're evaluating patients, it is important to keep in mind that patients who have cushingoid features on physical exam do have higher risk of developing GIAI. So, and these cushingoid features include the moon-like facies, the dorsocervical fat pad, the supraclavicular fat pad, the truncal obesity, the proximal muscle weakness. So it's always important to keep in mind these signs when we're evaluating and examining patients in the exam room.
Thank you very much. Are there other sources of exogenous glucocorticoids that the audience should keep in mind when thinking about GIAI?
Yeah, so there is this common perception that GIAI develop mainly after treatment with oral glucocorticoid. However, we do have a decent evidence that other formulas other than orals could also cause the same problem. I would like to start by highlighting one of the most common ones, and these are the intra-articular and the epidural glucocorticoid. The prevalence of GIAI actually was reported in the literature to reach up to 52% in patients receiving these injections. And this is more prominent after repeated rather than single injection. And especially when glucocorticoids are injected in high doses, or when the glucocorticoids are actually used for inflammatory disorders rather than degenerative disorders, or when the glucocorticoids are used simultaneously in multiple joints or bilateral joints rather than unilateral joints. One of the most common scenarios that I had in patient rooms when talking to patients is that when you ask them, have you been treated with steroids before? And a lot of the times they answer no. But when you ask them very specifically, have you received any steroid injections before? they remember receiving these injections, but a lot of patients actually don't recognize these injections to be steroidal injections. So it's always important to keep in mind that when evaluating patients, we should ask them specifically, have you received any injections in your joints before, and whether they were steroidal injections or not. Because a lot of the times, patients will not consider these to be glucocorticoid, and they will probably answer no if we ask them about any exposure. All right, so moving on, I think another one of the unrecognized but yet important sources of glucocorticoid is actually the inhaled glucocorticoid, the ones that are very commonly used for COPD and asthma. And GIAI due to these inhaled glucocorticoid was actually reported in up to 8% in the literature. And it was actually linked more often to patients who are receiving very high doses of these inhaled glucocorticoids, doses that could reach anywhere between 750 to 800 microgram daily. And they were linked particularly to the fluticasone propionate. And when patients uses spacer, so they have more of the medication delivered to their lung spaces. And in patients who have lower lung volumes, so reduced lung volumes. Also, it was noted that the GIAI due to the inhaled glucocorticoid was noted more in patients who received the inhaled and the oral glucocorticoid at the same time. So again, this is something that also we have to keep in mind when we're reviewing the chart to look for any of these inhalers that have been prescribed chronically for patients. All right, so as far as other sources, I should also highlight the topical glucocorticoids. And surprisingly, topical glucocorticoids can cause GIAI. And this was reported in up to 4.7% of cases, especially when the high-potency topical glucocorticoids are used, like the clobetasol and the betamethasone, or when they're used in high doses exceeding the 49 grams per week, or when they're applied on larger body surface so they have more absorption, or when they're applied in areas where the skin barrier is actually disrupted so they do have more absorption, or when they're applied on mucosal surfaces or surfaces that have higher absorption like the eyelids or the scrotum, or when an occlusive bandage is applied on top of the topical corticoid, so that leads to also more absorption. When it comes to other formulas, like the ophthalmic or the intranasal glucocorticoid, these have been rarely linked to GIAI. And then I think the last formula I want to talk about is actually the oral budesonide that is used sometimes for inflammatory bowel disorder, because budesonide also was linked to GIAI when given in very high doses. So when looking into the patient chart and talking to patients, it's always to keep in mind all of these formulas and not only think about the oral glucocorticoid, because I think most of them have been linked to GIAI, but with different prevalences.
Thanks. This concludes part 1 of this episode. Please join us for part 2 as our conversation continues beyond the pages.
Thank you for your insights in helping us to go beyond the pages of the Cleveland Clinic Journal of Medicine. To read CCJM articles, visit ccjm.org. To participate in other accredited educational activities, visit ccfcme.org. You can subscribe to the podcast on Google Play, Spotify, or however you prefer to access your podcasts.